Hi, I'm Dr. Celine Gelgec.
And I'm Dr. Tori Miller. Welcome to Breaking the Rules. On Breaking the Rules, we talk about all things OCD.
Obsessive compulsive disorder, OCD, impacts up to 1 to 2% of the population. We are here to provide not just education, but to inspire clinicians, families and people who are impacted by OCD to be able to access the treatment they need in order to get better.
Catch us every fortnight, wherever you get your podcasts.
Hi everyone, welcome to this week's episode of Breaking the Rules. Today we are so excited because we are joined by the amazing Dr. Alissa Knight from the Calming Suite Psychology Clinic in Adelaide. And of course, Tori's with us too.
Yes, I am.
Welcome, Alissa. Thank you so much for joining us.
I'm very excited to be here. It's such a privilege to be with you ladies, have this conversation today. And also thank you for the lovely intro. That was very nice and welcoming and warming.
Well, for people who might not know of you, Alissa, we actually came across your work really recently up at the Child and Adolescent Mental Health Conference.
Yes, that's right. Yes, that's it.
Yeah, in the Gold Coast recently, and went to one of your presentations, which was outstanding.
It was so good.
Oh my gosh, it was outstanding. And so I think we were about 5 minutes into your presentation and Celin and I writing to each other, PD for team and podcast.
Yes.
Oh my goodness.
So I think Celin had started scripting the email too before your presentation was
Finished.
even over.
Yeah, it's true. Well, as soon as you said yes, I was on my phone emailing.
Oh,
also paying attention. I swear I was paying attention. I felt like the naughty kids in the class, just passing notes to each other.
That's incredible. Just to know that I had that impact and to know that, again, my message and what I was trying to convey kind of reached you in that way is remarkable. Tells me that, for years and years I've been building up to like wanting to get across this extra layer of information about eating disorders, but also around so many different areas of eating disorders, looking at it in a way that we do have to think about comorbidities and we do have to think about the bigger story and the real realness of it too, the rawness of it. So I sort of stepped into that workshop in the Gold Coast and went, today I'm here. I'm going to deliver this as it is. I'm going to really tell the real story. I wasn't sure how it was going to be received, but to hear that you really felt it was that
brilliant.
way was great.
It was so powerful.
Well, I actually think that that's what resonated with, isn't it? And one of the things that we've struggled with, I think, in our search for connection with clinicians who sort of specialize in this area is about the realness of the work compared with how it's written about in text or how the training is taught. And there does seem to be a bit of a disparity between what it's really truly like to work with someone versus how we're told we should be doing. And I think that was so true. In your presentation.
No, thank you. And that was part of it is just, you do step out of university and you're primed and you're manualized and it's rigid and it almost, takes away from the real life person. Someone sitting in front of you, either in one-on-one or group therapy, we know their story is so much more deeper than any one little manual can produce. And so I think a lot of the time, I wouldn't go to the level of saying we're gagged, but obviously we're not really allowed to relate in many variations how real and raw it can be for some people. And that we should stick to the real sort of rigid way of, doing therapies or seeing these people and conceptualizing their stories. And sometimes I think, it really can reduce the impact that we can have. So if shifting into like 2026, I think now we all need to really step up in ways we can go, what is this like? What is this person fighting? What can we do more to really hear them and give them a voice and really echo that loudly? And I think as practitioners, we've hidden away from that. I think we've kind of really kept ourselves quiet to conform and really sit in that conservatory bias sort of lane. But I think now we've really got to march forward because otherwise nothing's going to change. Our children are screaming for us to help them. I don't even think yet we know the way to help. So that's sort of something I'm waiting for everyone to kind of get on board and go, okay, the way that we've been doing this for 40 years clearly isn't really giving that efficacious look, that lens that they need. What can we do? Why don't we use part of that, but build on it and make it something a bit more relatable in 2026?
Yeah.
Yes, amazing.
Do you think a part of that is how dogmatic some of the teaching can be, especially in workshops and stuff, but also how that translates with clinicians leaving those workshops with I don't know about like living with high anxiety, thinking we're going to stuff it up. And if we don't do it this exact way, then you cannot work with people with eating disorders.
Because your client will die.
Yes.
Yes. And, just perfectly as you put there, Celine, it's sometimes you even hear it from the hospitals where, they're telling parents, but also practitioners, if you do not rigidly map out their treatment in such a structured way, death is on your hands, as real as that sounds, as confronting as that sounds out loud. And so you've got practitioners who are like, I ain't taking that on. Like, what on earth?
It's too much responsibility for me. I didn't sign up for that. Yes.
I'm not having that on my hands. And also then, knowing that am I being a bad clinician by seeing the flaws, seeing the trauma, seeing the coercion and their rights stripped from them and removed. How can I sit in front of this 13-year-old and preach that and force them to dive into that when I know better? So I think you're right. The dogmatic side of it is we go to these workshops, we go to these conferences, more so in the university settings as well, and we're delivered this style of being a psychologist that's, monotoned, not really allowed to have an expression, not allowed to have empathy, and just sort of be there with them in that moment. And then here, you've got to go home and eat 6 meals a day. Don't care what you think. You're going to have the door open. All your rights are removed. And somehow think they're going to enjoy that treatment program with us. It's always so ironic to think they're going to trust us. They're going to feel safe with us. They're actually going to hear us and like believe us in what we're saying when they're the ones putting shackles on their feet and hands.
Yeah. Well, one of the things that I've certainly experienced is that sense of being caught in between two worlds, which is sitting in front of a client who I can see so much potential in and so much opportunity for us to work together in relation to who they are and their personality and their self-esteem and confidence and their self-worth and all of these things, but then feeling bound by the treatment that I've been told to give them and feeling like I have to set my instincts aside to say again, you have to eat and you have to do this and you have to do that and this is and going over and over and over it really rigidly. And I can see the client shut down in the face of that because it feels in a way actually, if I think about it, kind of inauthentic.
Absolutely. Yeah, absolutely.
So maybe, I mean, we've launched right in, but maybe we're going to talk about the intersection of OCD and eating disorders today, but maybe beforehand, could you tell our listeners a little bit about how you approach working with people with eating disorders?
Absolutely. Thank you for asking that. I think it's flowing off kind of what we've just spoken about. In sort of early in my career, I identified these holes. I identified that if you really want a chance to work with these people, particularly something like an eating disorder, you've got to know their whole story. Eating disorders and any individual that comes to see a psychologist, if they're battling any kind of mental illness, it's multidimensional. It's not one-dimensional. And so, for me, I always try to learn about their entire history, their entire presentation, their temperament, their personality. I kind of formulate it into a triangle where I'm like, right, we're going to go all the way to the bottom. This looking at you in the symptomization of, checking calories and reducing a few foods here and there. Tell me about that. Where did this start? This isn't your whole story. I want to know, like, when did this start? Was this like when you were a child? Tell me about your attachment to your mum. What was that like? Did you have any emotional neglect in your childhood? Were you suffering a medical illness? Was something like diabetes, or was there something that you were trying to control back then that felt really out of control? Talk to me about all of that. Have you got a predisposition as mum or dad, got neurodivergence in there, genetic disposition there? Like, what's that got to do with interplay and sort of how you presented when you were a child as well? What was school like? Did you have friends? Were you lonely? How were you in that sort of phase? Were you shy? What was that all like for you? And often than not, when we funnel all the way down into that traditional chain analysis, what we hear is, it was really hard for me. It was really hard for me. And then you're looking into that. What does that look like? So there could be trauma. There could be emotional trauma. There could be attachment issues. There could be genetic, as we're talking about, multiple layers. And often right at the bottom, we see trauma.
Mm.
Yeah.
So thinking that we're going to treat somebody with, anorexia nervosa, for example, ARFID or binge eating disorder purely with a food and weight restoration approach is completely neglecting the fact that we have these multi-layers going on underneath. And it's almost ignorant to think that you are just giving someone 6 meals a day when they haven't even eaten more than 500 calories a day. And now you've got them in there, forcing them with 3,000 calories a day. We don't care, apparently, if they've got vegan options. We don't care if they've got dietary requirements. We don't care if they've got autism or ARFID and they've got these real compounding sensory issues there. You're forced to eat this because the manual says so. And so, you put them in this program and then imagine what it's going to be like when they step out of that. How are they going to, really model you now, forcing them into this 6 meals a day and think they're going to maintain that and really be enlightened by that, empowered by that? My approach is to go, all right, I'm going to hold your hand. We're going to go through this journey together. We're going to work through all those layers that you just spoke to me about. Let's navigate together what that looks like in that multidimensional way. Do we start with often like, there's depression, there's anxiety, there's OCD, there's all these things going on. And then there's the perpetuating factors on the side, social media, the bullying, things like that as well. What is your home life like? Mapping out what makes sense to start and where. Usually I will try to target trauma right at the end because that's often the most hardest. So we'll do things like CPT or schema therapy. We're navigating all throughout. EMDR as well is really big there. And often as you build yourself through all these layers, you tend to see the food, the eating side of the weight side of it naturally starts to dissipate anyway. But we're still targeting along the way. It's not the first thing that I target though. I'll always make that really clear. I'm not going in and going, right, how much do you weigh? How much do you eat? It's often something I'll lean in after I've got that trust of them, after I've sat in front of them and said, look, I get this. You are a real person. I'm not going to force you. Let's do this as a partnership. You do it with me. I'm going to do it with you. And I want to get you to a place on the other side of this where you actually feel well. Let's drop the word of recovery. Let's leave that aside because a lot of them are very triggered by that. That single word recovery blows their mind. They really conceptualize that in the total opposite way that it's meant to be.
Because they perceive that as being fat or a bigger body. That's what recovery, is that what you mean? Or
a
is it
lot of
something
the
else?
time, yes, it is. I think it's sort of like they hear recovery as equals getting fat, right?
Yeah.
It's been stigmatized that way. It's been stereotyped that way. They don't hear it, feel it, embody it any other way. So we know this, particularly in this modern era. We know that the young people coming through, that's how they perceive it. So for me, I'm always trying to gear them in this land of wellness. I want you to think about yourself mentally, physically, socially, all of that together. What would that feel like for you to be that layer of wellness? And talk to me about that. I want you to give you all your dreams. I want you to guide me through all of that. And then we navigate it one by one. But often what I find is when you go in an approach like that where it's collaborative, there's no force, we go gentle, we go at their pace, you find that they're really happy to do it. And the weight and the food and you're involving them in all of that discussion, it comes. And it's a lovely journey. The relapse is really low, if ever, in my entire career have I had really people get on this kind of a journey with me, a multimodal type of journey and relapse. Rare that they drop out. Well, we know in traditional forms of eating disorder treatment, that retention rate is very low. Dropout rate, very, very high. Relapse rate, excruciatingly high. So I think it's time we need to look at it. We need to move forward. And that's kind of what I try to do now with the approach that I'm doing.
What a refreshing way. Like imagine being a client who's gone through the ringer and it is such a traumatic experience, in and out of hospital, dietitians, GP, psychiatrists, the whole shebang.
The whole thing fairly blaming.
Yes, exactly. And the scrutiny and all of it, and the power struggle at home as well. Like if you're, for young people especially, to then sit in front of a professional and go, how is this going to be different? And it's wildly different those first couple of sessions. Like I can imagine just shoulders dropping, guard dropping, and just building that trust and rapport so amazingly, because you can be the most skilled clinician, but if you don't have your client in terms of, if you don't build that rapport with your client, it's going to fall flat. We know that. Absolutely. So it just blows my mind that we still push that agenda of needing to and not work in this way.
Mm.
Do you know what I mean?
Yeah, I do.
Yeah.
Absolutely. I could not resonate that anymore. I think you said that beautifully. You know, when I'm bringing in people to train them, I'm like, look, drop everything. If you don't have the artistry of rapport, if you can't meet them in that first 30 seconds, you've lost it. Doesn't matter what therapies you're trained in. They mean nothing if you can't get that rapport and that trust in them. Your job as a psychologist is to be in that room and they're looking at you and you're like, you know what? You are so safe with me. You know, here in this room, like you mentioned, there is such a power imbalance when we go to hospitals. And then that power imbalance from the hospitals flows into their parents because they're also fear-mongered into believing that if they don't embody the approaches that they're taught and trained, then their child's going to die. It's on their hands. So that person's feeling all of that, you know, and then to think you're going to come and see a psychologist and you're just this next person that's going to march on order and do the same thing. It's crazy to think we're still embodying that. And I love what you said. I think we really need to try to learn the mastery skills of how do I connect? Let's go back to basics. Really like get this young person to see me as someone that's going to help them, not hurt them.
Yes.
Yeah. I would imagine, though, that plenty of practitioners who work with clients with eating disorders in a more traditional way would say that they have good rapport, that they are rapport-centered.
Yeah.
So what do you think the difference is between the work that they do and the work that you do?
Absolutely. I mean, I'm sure people around us, we know, they're trying their best, they do a really good job, and they probably do elements of rapport that's fantastic. You wouldn't take that away from people. They've all got their own niche, they've all got their own style. My style is I do bring in a bit of lived experience as well for me. I do sit there. I'm very myself in the room. I try to go less as a psychologist, less clinical. I will laugh with my clients. I will squeal if they've achieved something. I'm a very big personality in that room. And you kind of see their shoulders inch as they go, oh, she swore. Oh, I like you. You know, I'm on their lane. Whatever I can feel from them, I'm giving them. I try to match them. I try to make sure they feel comfortable with me. And a lot of the time, it kind of is that, you know, unicorn standing in a field of brown horses that they see in me, that they go, oh, gosh, like you're just normal. Like you are just me. Like you're like me. Oh, my God, you've got a background too. Wow. Like, okay. Like, you know, and I know that. So I think what the difference would be is I'm less clinical. Obviously, I bring in all the clinical layers. It's up here. I'm always delivering that for them, but I deliver it in a way that's really relatable, that's really upbeat, that's very dynamic and youthful.
Yeah.
Yes.
Which is so important. You need to meet people where they're at. Like we say that to our supervisees in our team all the time in terms of the OCD work as well. Just remember they're a person. And meet them where they're at. I'm going to play devil's advocate for a second. I don't think this at all, but I can hear certain colleagues screaming down wherever they're listening or watching this on. But what if there is real danger? What if you know, weight is so low and all that sort of stuff? How would you navigate that? Or the anxiety that some clinicians might be feeling, you know, that we were talking about before, because it's that thing of, their death might be on your hands. So how do we navigate that with this approach?
Absolutely. And that's a great question to ask because the reality of it is a very, very serious mental illness.
Yeah.
You know, we can't take away from that. It is. And you are dealing with a serious illness and there's obviously components of it that are physical and you know, we're looking at starvation syndrome. And the truth behold is, yes, there are elements of anorexia nervosa in its imminency that requires immediate medical attention. And despite whether, you know, and I embody this really compassionate sort of, you know, multimodal holistic method, there's still that duty of care. And so for me, obviously in outpatient therapy in private practice, we're not really supposed to be dealing with imminent anorexia nervosa, just for reference. We're really supposed to be dealing with clients who generally speaking, are above the BMI of 16 and don't really hold that medical instability that can't work with us in a one-on-one setting. However, they do creep through the cracks. And often that's coming off the back of phone calls. We've been doing this style of therapy. It's highly traumatizing for me. Can we try something different? And it's very heartbreaking to be able to say, look, we need to consider the medical side of this and make sure that you're ready, that you're stable to be able to do it. But I would say that, yes, if we're bringing them in for an initial interview and we're going through their data and we can see that they're very medically unstable, that they've got a tremendously low BMI, we obviously have to say to them, look, I understand, you're so desperate to do this approach and I really, really want to help you in that. But obviously the first step to this is we've got to get you stabilized. We've got to make sure that our first priority is your medical health, and very gently and safely I would word that to them. I would work with them then when they go to hospital, because I do have to send some people to hospital. I can't hold that risk for them if it's too high. I've got to protect them in that way as well. But obviously the goal then would be, instead of them going to hospital, stepping out of hospital and relapsing on 3 days, the goal is to go, I want you to use this time. I want you to see this time as getting your body back to a place where we're ready to do this. So I do work with hospitals very collaboratively. I've got a good relationship with some hospital staff members as well. And I would say to anyone out there, yes, you've really got to navigate both lanes. We can't neglect either.
Yes. Yeah. And what a lovely reframe of seeing it as a way to get ready for therapy, to do the work, It's a different approach and a different way of thinking about it, as opposed to recovery and how loaded that is.
Yeah.
Yeah.
Yeah, I agree.